it's actually kind of funny because Vic and I do go back very far. And in most good friendships, alcohol always has a place, right? So we were at a SUNA conference back in the early 1995, 96, something like that. I don't even remember what city. But there was about 5 of us from this Chicago area, and we didn't have a chapter. So we were kind of thinking maybe this is a great idea. It's a great organization. We learn a lot. Why don't we bring it back home? So that was the start of it. And, you know, we've got a great chapter now, and I encourage you all to stay active in it. That's what makes us as urology nurses so special, and PAs too. I don't want to just limit it. But what Dr. Patel was saying is that when you get into the urology field, you have a tendency to stay in the urology field, and we know that's true. And so we also know that the longer we are in it, the more knowledge we get, and it's important for us to share that. And so here's a little advertisement for me, is that I am president of the Sabuna Board of Certification. So I always push people to take that knowledge, challenge yourself, and become certified in urology. The good news is that we are 6 small questions away from getting national certification. So with the ANCC, that's been a 10-year progress for us, talking about it, and then finally doing it. So, you know, if you get certified now as a certified urologic nurse or urologic associate or nurse practitioner, it's going to carry a lot more weight, both in your job and with your patients, and hopefully with your salary as time goes on too. So, all right. So Katie came to me a few months ago and said, listen, could you do some talk about the caring for your bags and the tubes and urinary diversions? And I'm like, oh, well, each one of those topics is like an hour in itself. What do we should do with this? And I work out at Oak Park Hospital on 1 day a week. Are any of you from Oak Park Hospital? Okay. So it is a very tiny, very community-oriented hospital, even though it has the name Rush after it. So they don't have a lot of resources. They don't have a lot of urologic nurses. And so I sat down with some topics with them, and having been involved in cases where they didn't know if they could insert a Coudet catheter, there was obviously a big knowledge deficit. So I sat down with these topics and I said, if I was going to do a talk, what about these particular things do you think you want to know? So that's going to be the focus of this. I sat down with those nurses, we talked about what they didn't know. So as I go through these, I'm going to take a pause, and if there is at some point in time, like after we're going to talk about suprapubic tubes, so then we'll pause. If there is something about a suprapubic tube information that you think is important, I want to stop and I want you guys to share it with all of us so that we can then foster that and make sure more people know how to take care of all of these. So am I pressing this? Okay, so what type of urologic cancer could predispose a patient to some alteration in voiding? Because we knew that this conversation this week was going to be all about the cancers. So is it, you know, penile cancer, prostate, kidney, bladder, or ureters? So the correct answer would be all of them, and we'll quickly go through them. Dr. Patel did a great job of setting up my talk on the diversions and all that, so we're going to have some extra time here. So penile cancer, it's very rare in the United States. Mean age is 58. There's a couple of procedures that they do for it. They can do a partial penectomy, a total penectomy. Sometimes they have to add radiation, and then sometimes they can do chemotherapy. So if you have to have a total penectomy, we have to somehow get the urine out of that system, right? So one of the ways they can do it, they can create a little urethra in the perineal area, and the patient can actually void through that little perineal area. that is not how it works most of the time, but it is a possibility. So otherwise, they may have to have like something called a suprapubic catheter, and that works really well for these people. So then we go on to kidney cancers, and that's, as he was talking about, it's the third most common urologic cancer. Again, the disease of the old, and I love the fact that I'm sitting up here and it's saying 60 and 70 are old, because somewhere I didn't get that message that I am now old. So I dispute that. But I did one talk and we were looking up what is defined as old in the United States, and it actually is somewhere between 60 and 65. So we are elderly. Yeah. All right. So he also did quite a bit talking about the different procedures that we do for kidney cancers, and it can be a nephrectomy, a partial nephrectomy. And then there's some complications that can happen with this that are going to require some different ways to get the urine out of the body. They can develop a urinary fistula, they may require a ureteral stent, or they may require an indwelling catheter. And then many times we'll also do a suprapubic tube. Next we have prostate cancer. This is a very common cancer. It's rare under 40. And then again, the older we get, the more incidence there is. So we know that when we do the radical prostatectomies, we know they're going to have a catheter, temporarily, we hope. We know they're going to have incontinence. Sometimes this incontinence gets so severe, though, that they have to look for a permanent alteration in the way that they urinate. So there are patients who would end up with like either a permanent catheter or a suprapubic catheter, or, you know, we can also do the urinary sphincter and things. But it's a way that we would be altering their normal urine flow. The next one is radiation therapy. And, you know, radiation has improved so much over the last 10 years. We used to see radiation cystitis all the time. These patients would come in such discomfort. They burning urination all the time, blood in the urine. We don't see so much of that because it's much more focused and they know a lot more about how to deliver it. And then if they have the surgery and then they get the radiation and then we throw the chemo on top of it, we've done some serious damage to that bladder, and so they may have some current problems that are going to need some type of a diversion. We talked about bladder cancer a little bit. Again, the older you get, the more it happens. Males do have more than females. And what happens here is it can be intravesical therapy like the BCG he was mentioning. That can cause irritative symptoms that may require some alteration. If we do the urinary diversion and then we add the radiation onto it, we can create a lot of problems. And we'll talk about those at the end of our talk, and that's the ileal conduit, the neobladder, and the cutaneous. And ureteral cancer, again, that's very rare, and it's commonly associated with bladder cancer. Again, the mean age is 73. So, you know, when you talk about prevention, what's the one thing we can do to prevent getting cancer other than not smoke? Is we can just not get old. But I haven't figured that out so well. All right, so that again is going to be radiation therapy, surgery, and chemotherapy that are going to cause some problems with urination. So we have two kind of catheters that we're going to talk about today. The first is the transurethral, and most nurses I've met are pretty comfortable with it. That's where the catheter goes right up the urethra, and it's lodged in the bladder with the little balloon that holds it in place. Less common and and more concerning for a lot of the nurses in the hospital is something called the suprapubic tube. And that tube is placed just directly into the skin and into the bladder. So it doesn't need to go in very far, okay? And that's one of the things that's a little bit hard for people to understand, because when they're thinking about putting catheters in, they always just kind of think, well, so the urethra is this far up, and especially with the male, well, then I have to adjust it for this length and all that. So nurses taking care of suprapubic catheters are a little uncomfortable with the fact that it's only in such a short distance. Got a nice picture there which shows you one of the placement spots for it. It can also be more midline if they don't have an incision like this young man does here. So, you know, what is a suprapubic? It's an insertion of an indwelling catheter through the abdominal wall and into the bladder. So some of the reasons that we do it can be temporary or permanent. Urinary retention, post-op management. If they have other issues and you don't want them to get like excoriated on the bottom, a lot of times the physicians will just go ahead and put in a suprapubic so that we don't create other problems. If they don't have good mobility with their hands, as long as they've got a caretaker, it's an option for them. We might need to put a super tube in because of the cancer diagnosis or a side effect of the treatment. So when we go back and we talk about the radiation therapy or the chemotherapy doing some irritation, that would be why. If they have bladder cancer, they can have a lot of gross hematuria, and sometimes it can just be pink urine, but a lot of times it'll be blood clots after blood clots, and they'll need to have regular catheters put in because their urethra just can't hold that large of a catheter. And that can happen after radiation. It can happen after chemotherapy. We've done it with kidney stones too if they have a lot of blood. And then the other indication is when the bladder is so metastatic that they don't want to do a urinary diversion. Sometimes that's the best way to get the urine out because they're really not candidates for even like an ileal conduit, and they have a lot of blood clots. So, and their term of life is short, so this would be an option. All right, so there's a lot of advantages. Less urethral pain. Have any of you guys ever had a catheter in? And so you know that every time you move your leg, it's just causing discomfort. Long-term catheter use, you can have something called urethra erosion. And I've seen it so bad on the penis that the catheter has gone all the way down to the base of the penis. And that's pretty difficult to go ahead and repair. It requires some major reconstruction there. If they also have problems with fecal incontinence, and especially like with a female, you're less likely to want to have that urethra and that fecal discharge closer. So if you move that suprapubic tube up, they're going to have less fecal contamination, possibly less urinary tract infections. And then the next thing is it gives people the ability to still be sexually active. I have a person that is in my clinic right now. I live in the city and I work in the city. And you know, that's kind of like the old town west with guns and crazy stuff going on. And this girl is 25 years old, and she unfortunately happened to be in the wrong place at the wrong time, and she was shot. So she's 25, she has 2 children, and she's married. She has an indwelling catheter, and she's had this now for 2 years. Up until when I saw her about a month ago, no one had even talked to her about a suprapubic catheter. So she would typically have sex once a month just before she was going to get her catheter changed. So they would take the catheter out that night, they would have sex, she would go in like at 8 o'clock the next morning and have the new catheter put in. When you're talking about a 25-year-old girl who's already had all of these side effects and problems, and then you're going to take away her sexual relationship with her husband, who is a great guy and stands by her like you wouldn't believe. It makes you understand that we really want to, as nurses, focus more on the patients and what we can do for them. And then more improved personal freedom. You've heard all of our patients talk about how obnoxious it is to have that leg bag, right? So if you have that suprapubic tube and you connect it, you use the belly bags at all? So, you know, they're like the old fanny packs, and you just strap them around your waist. So in the summer, you can wear shorts, you can wear slacks easy, you can wear a skirt, and it's not as apparent to anybody that you have it. It's easy for patients to empty that. They can just stand right by the toilet and drain it down in there. There is no scientific evidence that shows that there is more urinary tract infections using the belly bag than the leg bag, which is what everybody would think, because we've always been taught you carry that bag down below the level of your bladder and you carry it around there. So if I'm wearing this around my waist, how is that going to get the urine out without causing more urinary tract infections? But it does. All right, so invasiveness, it does require you going to surgery. Sometimes it's just a MAC. Sometimes they do put the people to sleep. Sometimes it's just like a little bit of IV sedation and a little incision right there. With this, though, the sphincter still got to work. Because if you have like a small bladder or a detrusor overactivity and that sphincter isn't holding closed, there's not going to be any sense to put this catheter in because you're still going to leak if you have a big spasm. So you want to first make sure that they are holding their urine okay. There's also risk of bowel injury as you're putting it in. And then there's always the nurse practitioner who decided to cannulate the prostate while she was doing this. And this is my story, so I'll tell you that we all learn. First time I put a suprapubic tube in, I was changing it. I was thinking the same thing about the length of the penis and how far I have to go in. And so I went past that inch, I went past the 2 inches, I went past the 3 inches. And then all of a sudden, I'm getting blood. And I'm like, oh, what happened here? What am I doing? And this happened at DuPage Medical. I went and got one of the physicians that they work with. And he came in and he goes, oh, I think you're in the prostate. And I'm like looking at him. So I had pushed the catheter through the bladder and somehow managed to get it down to the prostate. As you can imagine, that patient wasn't really happy with me, but I will tell you I never did that again. And I make sure anytime I'm working with a nurse about suprapubic catheters, I go, just remember, it's only this far in. We're not going down anywhere else. And then the big thing that floor nurses worry about changing it themselves is, well, I was told that it closes quickly, and so if I don't get it in right away, I'm going to lose that channel, and then the guy's going to have to go back to surgery again. So that's partly true, partly rumor. Typically, you have at least 30 minutes to get in, and I've actually had suprapubic catheters be out for 24 hours, and the channel is so well open that you can get it in there. So that was one of the things that the nurses particularly questioned me about. So if it inadvertently comes out, what do I do? Should I try to recannulate it? Should I just call service? And that's one of the things that we work on. You just take the catheter, you try to place it, you try to get in, you flush it with some saline solution to see if it's coming out the catheter or if it's coming out around the catheter, and that will help you determine if you're in. So there's a couple of reasons why we wouldn't want to put a suprapubic tube in. Obviously, if they do have those strong bladder contractions and you have a suprapubic in and the sphincter is going to be spasming like this, they're going to be leaking. It's also going to cause more irritation in the bladder because that tube is going to be poking at that bladder all the time, and so it's already in spasm. You don't want to make it worse. If they have a small bladder capacity, again, the bladder is going to almost always be empty and it's going to be more irritated. You're better off with that just putting in a catheter that will be draining free. One of the pluses to a suprapubic tube, do you guys use catheter valve? Do you guys use a lot of suprapubics? Any of you use? All right, do any of you use catheter valves? So that's where they don't have to be connected to a leg bag or anything, and it's a particular clamp that just fits onto the end of a catheter. It's like the end of a leg bag, and it just folds up so it's not going to leak. And, sorry? Exactly like that. And if you don't have that, because I know all different hospitals carry things, we just use catheter plugs. So what's nice about that, there's no leg bags. I got the freedom. I have a patient that has a suprapubic tube, and he was connecting it to his leg bag, and he had his three-year-old granddaughter over, and it was connected. And you know, they have small feet, and they have gym shoes, and she was sitting on his lap, and she suddenly moved, and so her gym shoe caught the tube and literally just pulled it out. Yeah. So he was panicked because what's going to happen, and he was also hurting, and he didn't want to scare his little granddaughter, so he was like, I don't think I want to do the suprapubic tube anymore. So that was when I set him up with the catheter plug, and then because he was worried about her still being able to find it, we just had him put like one of those little stretch belts around so that it's tucked in. So there's no way, no matter how much she was moving, it would get down into that little belt and dislodge it. So that was just like a great option for him. So deciding like who could have it, they have to have that ability to open and close the clamp themselves. And if they don't, again, if they don't have a caretaker that's going to do it for them, I don't know that we have done all that much for them. Here's a nice picture of some of the complications that can happen. So we want to know that, there are complications with suprapubic catheters. And it makes us think, is this going to be a good candidate or is it not going to be? So there is increased mortality and increased morbidity. They can get the infections just like they would with a regular catheter. There's no indication that it's any higher in none of the data. There can be leaking around the catheter, again, just like with the Foley catheter. There can be that inadvertent dislodgement, which I just told you about. Again, with any kind of a tube in the bladder for any length of time, you're prone to stones. Supposedly there may be a little bit less with the suprapubic. They try to encourage people to drink better. And then catheters in the bladder, whether it's suprapubic or urethral, are associated with squamous cell carcinoma. And then there's the pain with it. I wanted to show you this picture because of another complication that we see with urethral catheters and suprapubic catheters. It's called encrustation, and you can see the picture, the little white that's around the base there, and then that can actually, you can see it's going into the little opening too. Have any of you guys had problems with people not being able to keep catheters in for any length of time because it does crust like that? So years ago, I was taught that when you get a catheter like that, what you should do is like squeeze it and break it up, and then have them drink a lot so they can flush that out. And then later on, we learned maybe that wasn't such a great idea because that encrustation is actually a combination of mineral salts that are found in the urine, as well as the film that when the bacteria adheres to that catheter. So when you're moving it, you're increasing the likelihood that you're going to cause a urinary tract infection. So if any of you have been told to try to get that out of there to increase the duration of that catheter use, don't do it. Don't do it. All right, so, yeah, Mira.
Is that a suprapubic insertion or a urethral?
This is a urethral. Okay. I couldn't find a picture of a super.
I was trying to figure out where did it go in the abdomen.
No, that was why I specifically said ureteral too. Just, I couldn't find any pictures of a catheter with incrustation from a suprapubic. So then one of the things that we were going to talk about with this was evidence-based management. And if any of you are in schools or you're in a hospital where you have to do quality assurance, some of the nursing studies that we need to do is in this level of nursing. We don't have a lot of evidence-based practice. So when I tried to go in and figure out what was going to be better, I did this big review online and wasn't able to find much. So as far as what we have with these catheters, there's a million different catheters out there, right? And they're always like, well, you should use this one, you should use that one. The bottom line comes down to there is no evidence that this one particular catheter is going to be the best. All right, we do know that we try to use silicone if it's going to be long-term, but that information is based on expert opinion, not so much clinical data that shows that the duration of the catheter, less complications happens with this. So then we have patients that have been instructed to irrigate your catheter every day, once a week, and there's no evidence to suggest or refute that. And I've started to use more catheter valves now. And, the question was, are you more at risk because you're breaking that system? You know how we're always told, don't break the system. In urology, we break that system the minute we tell them to take a leg bag home. But in the hospital, you never do that, But there's no evidence that's actually showing that you're increasing the infection rate by using those catheter plugs. But you have to know that the overall patient satisfaction has got to be higher when you're not carrying that on your leg all the time. So current guidelines also don't recommend a fixed schedule to change your catheter. So how many of us have been told every 30 days, you bring them in every 30 days? And then we went, well, maybe we could go every 6 weeks. There is no data to show any fixed scheduled date is good. What they do say, though, is if you have someone who comes in with encrustation and you know that it's blocking up every 4 weeks, then you should get the patient on an every 4-week schedule, okay? The next thing I looked up was, how do we clean the bag? So I looked up Cleveland Clinics, I looked up Mayo Clinics, and I went to NIH and I looked up SUNA. You were responsible for the SUNA one at one point in time, right? Okay, so SUNA requires bleach, right? Well, 1 to 10 ratio? Yeah. Okay. So it sounds like a great idea. Okay. Yeah, you're going to mix a little bit of the bleach in the bag and fluff it back and forth and then rinse it. The problem was nobody remembered the exact concentration, so they might not dilute it enough, or they might let it get on the bag, and then the bag was going to be on the skin and people were getting burns. So then they said, okay, well, I mean, when I was growing up, we just soap and watered it, right? And that was all we ever did. And so then they decided vinegar and water. So 1 to 3 ratio. And that seems to be working pretty well. The idea about the vinegar is that it's going to break up those ammonia crystals that line the plastic bags, and so it won't have that bad odor also.
You know what I use now?
Nope.
Mouthwash.
Mouthwash. And the clinical data is?
No scientific data. But I can tell you patients love it because it smells good. It's antibacterial.
Yeah.
And they don't get skin burns from it. So I like anything they want.
They were just asking what brand. And he's not being paid by Crust, so he would not say their name. Listerine. So this is areas of nursing that we need to think about. We need to say, well, let's figure this out, because we've been putting catheters in since metal catheters back in Egyptian times, I think, right?
You and I had to read in Egypt.
All right. So let's talk about your suprapubic catheters now. Any questions? Yeah.
One of the things I've seen on occasion is that men can have really significant penile pain with suprapubic. It's kind of rare, but there's a catheter called a duet. D-U-E-T, it's a double balloon catheter. Anybody looked at that?
So her question is that with suprapubic catheters, sometimes the men will talk about severe pain at the meatal opening, right? And she's got experience using a duet.
Well, I just read about it, and I wondered if anybody has used it.
It's D-U-E-T-T-E. Duet catheter. Has anybody heard of that? All right.
So I'm going to give a rep.
Yeah. Which company makes it? Do you know? Do it.
But it's a double balloon. Somehow it reduces.
Oh. She said it's a double balloon catheter, and somehow it's been associated with less meatal discomfort. Yeah. Yeah. Great. Any other questions about suprapubic catheter? Yes.
We have a patient who's has MS and in a wheelchair and has a SPC, and we have a problem where she gets this constant increase in sediment, and it'll block the tube. And so we currently have her come in every 4 weeks, I think. And there's an occasion where she said about the ER because it stopped raining, and so we've been trying to have her increase fluids and just trying a variety of different she does get, yeah, she gets this constant sediment, buildup in her, and, you know, when the caregiver can move it a little bit, and, but is there any suggestions on what kind
So
of
she's talking about a spinal cord injury patient that has a lot of sediment that builds up in the catheter and then it blocks up. So of course spinal cord injury patients are more prone to that. Okay, but they have more likelihood of that because they are not moving around as much. So they have that urinary stasis. So that promotes that. So you go back to those guidelines, you know, do we irrigate, and is that going to be helpful? And there's insufficient evidence to indicate that irrigating the bladder every day is going to help. I personally do have my patients irrigate the bladder. I have them push it in and then I have them pull it out, because a lot of times that sediment kind of collects on the bottom of the bladder, and so I do have, it depends. Yeah, so the one guy that does it, he doesn't have to do anything for the first 2 weeks. He's good for the first 2 weeks, and then it seems like for the next 2 weeks he can slowly see it starting to get more sediment in there and less fluid coming out at a time, and so then he irrigates it and it'll keep it open for additional 2 weeks.
You have to use Renicidin?
Yeah, and so some people do. It's not in the guidelines as recommendation of that though. Is that what you use on a routine basis? It can be pretty toxic. Yeah. So you want to, can you talk about the dose that you use or how often you do it? Yeah,
Renacidin. Renicidin. GU irrigant. It breaks down crystal formation. Not an antibiotic, it breaks down crystals. You use 60 cc's, you leave it in dwelling for 20 minutes, and then they drain it.
Yeah, we only leave it in like 10 or 15, and then they drain it out. Yeah.
we used to use it for our continent urinary diversions because they're more prone to stone development, and so we would do that frequently to minimize the stone burden. Yeah. Lori?
What do you do with granulation tissue? At what point do you, I don't know if people overnitrate them like you do or you don't?
So Lori's asking about the granulation tissue that can form around the catheter?
Yeah.
Right.
So do you, I mean, sometimes they bleed a lot, so you use like silver nitrate. Is there any other?
That's what I do. If it's really bad, I use silver nitrate on the area. Nance, what do you use? You see a lot of that? You use silver nitrate too? Yeah. Yeah. Did one of you over here say you use vinegar and water too? And so what's the concentration that you're doing that? Yeah. So when you are going for magnet status and you want to do your level 3 or something like that because you get more money on the units, why doesn't someone do a study on that? Figure it out. Because that is old school, but sometimes the old school it works. Yes? Oral lithostat? So they put it in their mouth? Or so they don't dissolve it and put it in their bladder? Okay. Okay. Okay, I'm going to move on. Ureteral stents, that's a thin catheter that gets placed into the ureter to maintain patency. It's placed under anesthesia. Reasons that we do it are if intrinsic is where there's an obstruction from within, that could be a stone growing up into the stent. It could be a tumor pressing on that. It can be from clots, or strictures. Extrinsic is malignancies that occur outside of the bladder and are actually pushing on the ureter and not allowing it to drain properly. It can be post-operative stent placement. That's usually short-term, and that's usually to help the ureter reconstruct without a lot of complications. All right, here's a picture of the stent. Complications can be seen in up to 85 to 90% of the people with them. It causes discomfort, irritative symptoms such as frequency, urgency, nocturia, and dysuria. We can have flank pain with that, suprapubic pain. My patients will describe it as like a poking sensation in their bladder. I feel like something's poking me. And I can cause some blood. Here's the thing. How many people do you think really want to have sex when they have any of you had stents in? No. Well, let me tell you, I think a stent in would be, and sexual activity, the last thing I ever thought about, tell you. It is the most uncomfortable thing. So we know that they're going to get encrusted. We can have problems with stent failure and stent migration, meaning it moves out of the area. As I was looking up the research, stents, if they are placed in the upper half of the bladder, less likely to cause all those complications than if they're put down lower. Okay, so evidence-based. So stent symptoms are not related to size or material. So for those of you who are treating people with stent for that pain and discomfort, NSAIDs and narcotics will help for stent pain. However, it won't do anything for the frequency, the urgency, and the nocturia. Okay, but that's where the Flomax and the Uroteral would come in. Here's the other thing. If your patients do want to be sexually active, Ureteral will help that. All right. I think in the interest of time, I might kind of stop this because we did get started a little late. Do I get extra time because of that, Vic? He's saying no. All right, percutaneous nephrostomy tubes. So that's a tube that is placed directly through the skin, directly into the kidney, okay? Again, the indications for a nephrostomy tube are the same as the ones for the stent. We want to talk about protecting the upper urinary tract. We want to make sure that we're getting that urine out of the system before it backs up into the kidney and causes problems. And the reason we do it can be from radiation, from surgery, from tumors. Also, if someone comes with a renal mass or an injury and they have renal hematoma, that would be another reason for using it. Some of us at Loyola, when I was there, they would inject the BCG in through a nephrostomy tube. So you know how you can have urothelial cell carcinoma going all the way up into the renal pelvis. So they would put a nephrostomy tube up there because you wanted to get that renal pelvis and you want to get it down the ureter the entire way. So we would lay the patients flat and then we would instill the BCG at a drip rate, a very, very slow drip rate, so it would be in contact with that tissue for longer. I don't think there was a whole lot of clinical research done on that, but obviously he knew what he was doing. All right, so here's a picture of the nephrostomy type tube. It goes directly in. And again, this is different tubes can look slightly different and they have to have a bag attached to them. There are times where not only do they have a nephrostomy tube, they also have a ureteral tube that will then go on down the ureter, go down into the bladder. Complications are only seen in 8 to 10% of the people. They can also have all that incrustation we were talking about. They can still have urinary tract infections. This is one of the things that the nurses on the floor were so worried about because you got a tube that's directly into the kidney. I just see the bacteria going right in there. So it was kind of interesting to show them that the data was not there, that as long as you keep the tube secured, it's not getting inadvertently pulled, you've got it covered, the risks of infection are not outrageous. If going in, it's not done properly, it can cause a pneumothorax. And then sometimes, again, when it's being placed, you can do some injury to the intestine, like putting a hole where it wasn't meant to be. All right, so again, NSAIDs and narcotics can relieve the nephrostomy tube pain. You can talk about using Flomax and Ureteral. And this last one gets into the concept of stewardship of antibiotics, which is like the latest hot topic. You know, don't abuse the antibiotics unless we have to. So they used to just put people on like one dose of Cipro every day when they would have these nephrostomy tubes in, just to make sure. And there's no data that backs that up. Okay. All right, surgical urinary diversions. The first one is an ileal conduit. So nurses on the units have not had the experience. You know, we don't get taught how to take care of that in hospitals, in our training program. Some hospitals are lucky they have stoma nurses. They don't all. And Rush Oak Park has one that is just new. So she is basically like a floor nurse that got put into this position, and the patients recently have really been having a lot of problems with this. So usually we do it for bladder cancer. Again, there's more males with cancer than females. Tobacco, chemical agents. Dr. Patel did a great job about why we need to do it with certain types of cancer. He drew that red line and said, you know, above is topical, below is surgical intervention. If you are going to get certified, I do want you to know that TNM system and what it means, because that guides the care that you give, and it also gives you an outlook about what you need to be watching for is complications in the future. All right, so we've got stoma complications. Any of these, stoma, peristomal hernias, skin problems, somewhere between 15 and 65% of the patients will have some type of complication early on with this. All right. The staff wants to know how to care for the stoma and how often to change the appliance. One of the things that I do is I tell them that every time they come on a shift, they need to assess that stoma, and they look to see, is it pink? Is it moist? Is it nippled? Is it draining? Are the stents in there? Are they working? And then how often you change the appliance. When they're brand new, I have them change them every 3 days, because it's more memory. You know, if you only do something once a week, every time you do it, it's like a new learning experience. So you have to do it a lot in the beginning. But then after they're down the road and they know how to take care of it, you can leave a urostomy pouch on for 7 days. There's a huge alteration to the body image that we need to prepare these patients for. I know Dr. Patel said that something like, 95% of the people have ileal conduits. I think that's kind of a shame, because it really affects how they feel about themselves. You have to have this bag on the outside, whereas some of these other diversions, it's not as apparent. I think that that's something that it needs to be looked at a little bit more. Obviously, there's some times when the patient is just not a candidate for it. So here's the next thing. So you need to catch a urine sample for these patients. Floor nurses typically don't realize or don't think that they can't just open up that urostomy bag and take it from there, right? So not a good idea. You can never just open the bag and take it from there. So we teach that. Then we go, well, how far back do we have to go? To be honest, if you are really doing a urine culture on a patient, it's because you're concerned about whether they have an infection. So you shouldn't even just pick off, if it's a two-piece, you shouldn't even just pop the bag off. You should go down, take the entire appliance off, clean it, swab it with betadine, rinse off the betadine, because the betadine will affect your culture results, and then dab it, and then put a catheter in there. Now, you're going to put a catheter in a stoma, right? So most people don't even think about doing that. How far can you put it? How long is the typical ileal conduit, right? Only about this far, all right? So you put I use a red rubber catheter. I put it in, and then I kind of crudate the area around it, because a lot of times the conduits will kind of get like a little bend, and so you'll actually have some urine that might collect in there. Sometimes it might take you 10, 15 minutes with that tube sitting in there to get the urine. That is the only good way to get a urine culture, okay? So when do we treat them? Just because that comes back with like 100,000 of E. coli, you want to know as a nurse that you're not treating that patient, right? They're always going to have bacteria in that. So what you want to do is you want to say, okay, fever, chills, nausea, vomiting, flank pain, suprapubic discomfort, and also they might see a lot of mucus, an increased amount of mucus or more blood in the urine. And that's the only time you want to pursue that. I've had men who worked with physicians, primary care physicians, they drop off their urine and they were just on antibiotics almost nonstop. And then I get in there and I'm like the Gestapo with antibiotics. It took him a while to kind of get used to that technique, but he realized he never got worse. So when the nurses in the hospital are seeing a new urostomy patient, I try to have them do a two-piece system rather than a one-piece. Part of it is cost, because you've got the cost of the wafer and the cost of the bag versus one where it's all together. But if they put it on and it leaks, you have to do the whole thing, whereas if it's a two-piece and maybe you just didn't snap the bag on right, and it's easier for them to actually visualize the stoma and see it. So I like to start them off in a two-piece. All right, here's a picture of a perfectly nice stoma. It's pink, it's moist, it's elevated. You need to remember that when you're working with these patients, they are grossed out by this, okay? Totally grossed out. So when you're talking about stomas, you need to be very positive. I use the term, it's pink, it's moist, it's nippled like a baby's mouth. And so they're like, oh, okay. So they get the clue and they're not as like grossed out by it, whereas, you know, sometimes you'll have their family members in there and the family will go, ooh, not good. This is another example of where a stent would also be used. These stents come out before they go home. So some stoma complications. Normal stoma on the left, that's a prolapse stoma. The next one is a combination of a couple things called a mucocutaneous separation, where the skin that was holding around the stoma, that's separated out, so it's opening up a little bit. The stoma is also slightly retracted, which makes it more difficult to pouch. And you know, a lot of the floor nurses have not had any experience with that, so they're not aware of all the products that are available. Next one, you've got a peristomal rash going on there. The next one is a giant peristomal hernia, and yes, you do see stomas that big, or hernias that large. And then this is what you always want to make sure that they're looking for with the black. That is a necrotic stoma, requiring immediate assessment by the physician. So the next one is a cutaneous urinary diversion. This is the one where they take the bladder out and they take a section of the intestine. They have a long section like this. They do what they call detubularize it. So they cut it right down in the middle and they kind of like fold it over to make a new pouch. They sew the ureters back into it, and then they take a little piece of the intestine and they bring it out either your left side or right through the umbilicus, okay? So it has, as far as continence mechanism, they take the ileocecal valve and they turn it around. My experience with them is they are very continent after this, and that's why I like it. It's a nice option for someone that doesn't want to be wearing the bag. Obviously, there's a learning curve when you're creating them. It's nice to have a wound ostomy nurse coming in to get the best placement for all of your ostomy sites. It makes it much easier, so you're not in a skin fold. Again, mostly it is done for bladder cancers. We've also done it for, in the past, interstitial cystitis, and we now know that that's not a good option to do that, but we didn't know that in the past. The main types are kidney pouch and the coke pouch. Here's a picture of it. I did this picture on your right just to see the catheter, because after the surgery right in the hospital, you're going to have a tube that comes out of the bladder itself. You're going to have 2 stents that are going to come out of the stoma, and you may still even have a catheter in the urethra, just in case there was any like serous drainage that was coming out of that. So the size of these continent diversions are very small to begin with. If you think about the size of your fist, that's the size. So they hold about 25 cc's when they're fresh. So you have to make sure as a nurse that that tube is draining correctly all the time. If it's slightly kinked, it's going to be discomfort in the abdominal region, and then there are cases where it could actually rupture, and that would obviously be very serious. There is a good level of continence with them, low level of infection. Like Dr. Patel did mention, it is more intense in your care in the beginning until you learn. And then it's easy. It's once a day you rinse it out with like a saline solution to get all of the mucus out of there, and then you just put that catheter in every 3 to 4 hours based on your fluid. There's no nerve endings in there, so it's not uncomfortable. So like sometimes you'll get a man who's a little intimidated like that because he's had penile catheters in and he knows that that's uncomfortable. There is no pain associated with this. Obviously, the big thing we want to do is make sure that we're protecting the kidney so that there's no infections with that. One of the things we worry about is the stoma can get smaller and stenose down, and it's a little bit harder to get catheters in, so you watch for that. And then sometimes the ureters can get kinked and form structures, because when they're sewing the ureters back into the bladder, they do something that they call intussuscept. So they kind of go in and out in the layers. So that's a secondary continence mechanism. And then there's always the few that do have incontinence. And they're doing other things that they can with that too, like even putting incontinence mechanisms with those. We kind of talked a little bit about how to care for the pouch, how to drain it. UTI prevention is the same thing it is with anybody. When someone's getting a urinary tract infection, what's the first thing you always tell your patients to do? Drink, drink, and drink, right? Just have them do that. And then we always want to make sure that the area around the stoma stays natural looking. So if they're getting rashes, we want to take a look at maybe they've got like a yeast infection in the urine. Sometimes they cover it with gauze because they're leaking a little bit, and we may need to put them in a different product for that to keep that skin healthy looking. Okay, I'll do this in like 3 minutes, all right? Surgical urinary diversions, the next one is the Neobladder. I love this one. This is where you actually recreate a bladder out of different parts of the intestine, and it gets reattached to the urethra. So if you want to talk about something that has the least impact on the quality of life of patients, this is the one. With this, you need a highly skilled surgeon, though, someone who understands the depth of how much of the sphincter he removed. Because, you know, with a female, it's a little bit harder because our urethra and our sphincters are only like 1 inch long. So that's why these works better with men, because their sphincter is longer. And so if he's doing it for cancer, he has to really calibrate how much of that sphincter he is leaving that can provide the continence. So with these patients, we just have, again, their pouch is even smaller. We have them urinate every hour to every hour and a half for a couple weeks, and then they go up to 2 and then eventually 3. So for both of those diversions, their cath schedule should be like a normal schedule every 3 hours. Less urinary tract infections with this. They do produce mucus. So like if they come with like the flu or something like that, they will notice that there's more mucus in their urine. So you like to make sure that they're aware of that, because when they're sick, their bladder area is going to look sick too. So they don't have an infection, but they're going to have some of that cramping that you might get when you don't feel good, and they're going to have more mucus production. So as far as indications, we're just talking with bladder cancer here. Okay, so here's what it looks like. Tiny pouch, ureters are sewn in, and that's it. If we have time for some questions, if you guys have anything that you want to add on the care of those patients, I'd appreciate that. Yes? A stent tracker? Okay. So her question was, is anybody utilizing the Boston Scientific program for stent trackers? Oh, big brother again. Well, and so that's one of the problems is that you forget it's in there. Maybe you're senile or something, and yeah, and they can actually scar down into the. Right.
So I track the stents for
Yeah.
surgeons, one of my roles, and I self-appointed because having people show up with a stone encrusted stent, and I've tried using like a stent tracking system that these, but not had any success.
So you purchase your stents from Boston Scientific?
No, they have a, you know, like a computer program where you can track stents, like who has them and.
You register your patients then? Oh, so it's not like a little device on the stent. Oh, that's what I thought it was.
I haven't been able to get it to work. I was just wondering if please have to do that with it.
I don't know. Has anybody done anything like that? All right. So do you call these patients every 6 months or?
Yeah, I mean, when I started working, I was coming across stents on CTs that were very old or encrusted, one that was broken up, and I was like, okay, that sounds like a job for me to make this not happen anymore.
So stents should be changed every 3 months. So you keep a running list.
Sure that they come out and
Right.
they're temporary or they're exchanged and
Right.
not.
Okay.
And the stents fly in at a high rate of speed, so it's just, I didn't know if anybody had any knowledge, like a law.
Yeah. I don't think so. Good thought. All right.
Thank you, everybody, or thank you, Kathy.